So, good afternoon, ladies and gentlemen. We will continue with a session of debate, and then we finish afterwards with case reports from young investigators. So it's my pleasure to introduce the first debate together with my co-chair, Sacher. And this first debate is about percutaneous mechanical support for VT ablation, whether we do need or we don't need this support for most of our procedures. And proponent is Della, and antagonist is Fred. So please, Paolo.
Good afternoon, everybody, and welcome back. Did you relax after your case, Joseph?
I did another case in between, so
without hemodynamic support.
Without hemodynamic support, even without general anesthesia.
What a title. I'm not sure I will win this debate. I'll try to do my best. I feel a little bit like that Greek soldier, I think his name was Aeneas, that taking the decision, should he go or not into war, interrogated the Cumaean Sibyl, and she provided him this kind of answer: go back, no, you will die in war. And the meaning of this was largely dependent on the position on the comma. So do it if the comma is just before none. Don't do it because you're going to crash if the comma is after the none. What a situation, because really I would say, yes, how can you do without it? And I try to put you some facts, and of course it will be a pleasure for me to debate with Fred. Now, of course it's a matter that is still debated, since data that are available for us were originated by retrospective studies with a limited number of patients, of course critical patients. Now, current ESC guidelines, the recently released guidelines on management of ventricular arrhythmias and prevention of sudden death indicate hemodynamic support with a Class 2B indication for acute management of life-threatening situations, but statements on the use of hemodynamic support during VT ablation are lacking. You can see this. Mechanical circulatory support, really like a Cinderella, receives a humble 2B indication together with autonomic modulation to treat monomorphic ventricular tachycardias when everything else has failed, and more or less the same fate is for patients that are suffering with polymorphic ventricular arrhythmias. However, the recent literature for the management of ventricular arrhythmias is full of papers, and I quote a couple of them, that really try to understand when and how do you have to deal with patients that are likely to crash. This first paper that we published 10 years ago, reporting on our preliminary experience of the VT unit, at the time we had about 530 patients, tried to decide how should we go on with the triage, set a decision whether the patient that we had to treat was a high risk or a low risk. And that algorithm that still is working today is based on a three-item decision algorithm. First, arrhythmia presentation pattern, electrical storm, incessant VT, paroxysmal VT, hemodynamic tolerance, yes, no, and comorbidities. And you see here that high risk, of course, patient that comes in with hypotensive electrical storm is high risk. But also, nevertheless, you see that the patient that comes in a seemingly so to say, easy situation, paroxysmal, seemingly tolerated VTs may nonetheless turn into a high-risk patient due to the presence of comorbidities. And of course, high risk means how to deal with this patient, how to avoid the crash, how to fight together with intensive care specialists to provide, of course, hemodynamic support. The colleagues of Philadelphia, shortly after, just went into the same problem, because when you do many cases, of course you hit against the high-risk patient, And they came up with this nice painist score. To me, relevant is that they also proved that roughly 10% of the patient population that they focused on this analysis had what they call AHD, acute hemodynamic decompensation, that actually was independent from the VT that had been induced. Just the patient was there, he was in heart failure, maybe the anesthesia gave him the last hit, but actually the situation became so heavy that it could not be possible to go on with the procedure. And of course, these patients are identified by the usual indicators, class 3, 4, ejection fraction less than 25, electrical storm, other comorbidities, including respiratory and renal disease, and of course, this portends a bad prognosis. A few years later, we have reported on the use of ECMO to support hemodynamically high-risk situations, and here we published this in 2016 on a population about 850 cases, of which 64 were deemed at high risk and were treated by ECMO. And of course, as you can see here, all of them presented with untolerated VT, 1/5 with cardiogenic shock, 2/3 with electrical storm, frequently in incessant VT, ejection fraction 27%, so it kind of a sick population. And one of the take-home messages from their experience is that you probably don't have to use hemodynamic support as a bailout. When you're on the EP lab with hypotensive, a fast VT, and the patient is going into shock, it's too late. You should provide her with preemptive hemodynamic support that is actually guided by the risk stratification algorithm that you are using at your own institution. And actually that went very well because patients that were non-inducible, green line, had a much lower recurrence rate of ventricular tachycardia as the patient that could not be treated out of the VT. And fair enough, the status of non-inducibility after ablation supported by ECMO was also a predictor of long-term survival, as you can see here. Survival here is about 3 years, as compared to those that could not be treated. So that really sets a rationale to preemptively identify patients that are high risk, treat them out. The meaning here is not to treat that fast VT, but to be able to provide reasonable, long-lasting cardiac output into a failing heart that might pay significantly the invasiveness of the procedure of catheter ablation. What has happened over the last years? I really decided to split our experience on our high-risk population in two. I chopped this in two parts. The first part is 2010 to 2020, and the second one, 2021 on. I'm counting here only patients that went into ablation because, of course, severe heart failure, class 3, 4, ejection fraction less than 25%, that actually more or less happened to be in the range of 25 patients per year, 270 in 10 years before, 50 in the years after. And the thing that I can say that probably the patient population is slightly improved. You can say it. It's not ironic, but average ejection fraction of this sick population increased from 21 to 26 over the years. Amiodarone use is less. Class 4 is less. I take it as a good indicator that people are willing to send patients to catheter ablation a little bit earlier as compared to what they were used to do 10 years before. Etiologies, as you can see here, main driver is ischemic cardiomyopathy, and among patients with non-ischemic, the red part of the pie is non-ischemic dilated idiopathic cardiomyopathy. So this is the two bad high-risk situation that you might encounter. Now, just to raise the ball to Fred, because he's a nice guy, I have to share with you admittedly that things also have changed over years. Because, as you see here, let's go to the last red line, the percentage of patients that underwent ablation procedure, and we're talking about high risk here, was 21% in the years between 2010 and 2020, and became 6% in the last 3 years. So something in our attitude has changed. And also, admittedly, although there were less VT terminated during procedure, 74% in the former years versus 50% in the later experience, the number of patients that were non-inducible at the end of the procedure were roughly the same, 76, 74%. So that also, we know, portends a good prognosis. Complications were more or less the same. Now, let's talk about the pros and cons, because then we have to debate, should we do it? Yes, no. Cons is easily said. It's complicated. To set up a hemodynamic support program is complicated because it involves a lot of other personnel, intensive care, perfusionists, people that really can do their job, which are important players, and because it's a complicated job, the procedure entails complications, vascular complications, cardiac complications. And of course, you do it because of a pro. What does hemodynamic support allow you to do? Of course, activation mapping during VT, and by the support to low output, long-lasting. So it entails pre, intra, and post-operative support, not just that VT. Also because let's analyze what has changed in the last year. I found that the number of VTs that we think were unmappable has drastically diminished because maybe we became a little bit more skilled, or also because technology is helping us. And I'm making the case here for high-density mapping, whereby a VT that was previously thought to be unmappable becomes easily and thoroughly mappable. So look at this patient with a prior anterior infarct. On your left, the voltage area. Yellow dots are conduction system locations, so his bundle, left bundle, superior, inferior fascicle. And on your right, propagation pattern with an area of late potentials, abnormal potentials that you see on your right. Leave your multi-electrode catheter there, induce the VT, and look at this. This is an 8-second movie. It takes exactly 8 seconds to localize the area of mid-diastolic activity here. All of this started at 10:28. This is just a static frame to say, okay, we are just in the middle, mid-diastolic activity here. We like to put a green circle around. Spontaneous degeneration into a faster monomorphic, even less tolerated VT after 30 seconds. Shock the guy. At 10:29:59, so 1 minute, 11 seconds, the mapping procedure of 2 untolerated VT has been completed. Ablation is then performed during sinus rhythm to achieve prevention of any other VT and abolition of late potentials. Of course, you would not need hemodynamic support. It would be crazy, insane to set up such a machine for something that now you can do much better during VT in 1 minute and 10 seconds. So that wasn't really even conceivable 10 years ago. Now, not always, however, it is like that. Take the other extreme. 72-year-old gentleman, IDCM, ejection fraction 19, and diastolic volume 460. A lot of comorbidities, severe mitral rig, chronic kidney disease, refractory electrical storm, high risk. The guy comes in with a kind of a scarring process in the setting of non-ischemic cardiomyopathy, no late potentials. There is a lot of abnormality along the septum. You would not really hang up to any abnormality of propagation during sinus rhythm. So you need to do your VT mapping, and here we are. This hemodynamically untolerated VT is tolerated because the guy is on ECMO, and it brings along to VT termination and proper set of lesion setting, program stimulation right and left, non-inducible. Then we go to an even more extreme case. This very unlucky 62-year-old gentleman that suffered an acute extensive anterior infarct. After a few days, he went to emergency cabbage. The surgeons did quite an extensive work of trying to revascularize the left system. Something went wrong. It went out in cardiogenic shock after surgery. He had a lot of post-operative ventricular arrhythmias. He went into emergency coronary angiogram. He suffered from a dissection of the lane main to the proximal. He had also an aortic hematoma. He then went into this incessant pattern of untolerated VT, PVCs triggering VF. He was sent to us to really try to manage this electrical storm. How could you do it? How could you do this without hemodynamic support? He was preliminarily treated with the Impella. And at admission, yeah, you had this kind of nasty-looking early PVC pattern, but overall a stable rhythm. Problem is that he went quite frequently into this type of unmanageable electrical storm, and Impella was completely ineffective, so he was put on ECMO. On ECMO, we went into the EP laboratory, so we like to share the groins. Right is for us, left is for the perfusionist. ECMO was at a full throttle, 5 liters per minute. And okay, again, initially sinus rhythm, then we go into VT, 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 like this. So there was no way to take this procedure during sinus rhythm mapping, and we went on during VT. We like to, again, as said before, chop the diastolic interval into 3 parts, entry, medismus, exit. So we went hemodynamically supported into this mapping procedure. Everything here is in entry. Now get isthmus is in yellow, exit here. And just to let you perceive, we were dealing with this gigantic wave of activation that was sweeping around the ventricle. There is nothing to do focally. And actually, it took us, the numbers here, are, although I put circles, are so small, 55 minutes of uninterrupted RF to take this to slower rates and eventually to get it on the right and terminate this VT. Man left the hospital alive. ECMO was went 4 days after. Rhythm stability, ICD-CRT implanted, and the man is fine. Okay, now, just to set my position quite clear, yes, we should at least be able to provide hemodynamic support. Although this has lately undergone a critical reappraisal because the support of VT mapping is becoming less needed. We are now able to map VTs that previously were thought to be unmappable. And again, there are no literature data to really support this indication. Now, so far to me, the decision to proceed to hemodynamic support for catheter ablation should be taken to multi-skilled agreement to provide adequate pre, peri, and post-operative cardiac output for critical VT storm situations, or in patients with advanced heart failure requiring treatment of ventricular arrhythmias in their status. Thank you very much for your attention.
Give his view of the problem or the debate.
So, thank you very much. Thank you very much, Paolo, because you admit you didn't need hemodynamic support. So that's great, and I think we will agree. We will agree at the end. And of course, he told you you don't need it, and that's true. When I look at these different studies, no trace of hemodynamic support. You know, this was a substrate-based paper, Partita, very important paper. No hemodynamic support, and in none of this paper you need hemodynamic support. So Paolo don't need hemodynamic support. So really thank you to have me the con position, because I think you would have loved having the con position. So let's look a little bit at the studies looking for hemodynamic support. So this is one of the first study with the Impella 2.5. That just shows that it was safe and feasible, but nothing on outcome and on efficacy. It was doable. There is a multicenter study, and Paolo said it. There was a lot of monocentric study or small studies. And in this multicentric study, once again, the conclusion that it was feasible and on a very limited number of patients, but nothing on the efficacy and no comparison group. So is it better than something else? Just like substrate ablation we discussed earlier. And here is one of the first studies that compared mechanical support for VT mapping and ablation versus substrate-based, because it's not that or nothing. We have alternative to hemodynamic support to map VT, except in some condition, that's true. But in this case, what it has been showed, and that's pretty interesting as a conclusion. Look at that. It's feasible alternative to substrate mapping and allows outcome comparable to substrate mapping. So it's not better than substrate mapping, but it's longer, no difference in efficacy. Complication was higher, even not significant, and was more expensive. So why using something more complicated that takes longer time and is not better? And this was the outcome. So when we look at other study, it is the International VT Ablation Center Collaborative Group study. So it's retrospective but multicentric with a high number of patients. Hemodynamic support for VT ablation represents 6% of all the cases. Once again, it's not randomized and comparison with all the bias, but and there may be a referral bias, and when you think you need hemodynamic support, your patient may be much sicker. But anyway, in this study again, no difference versus the control group. So in patient as sick as the others because they have been matched, but without hemodynamic support, so going for substrate ablation, there was no difference in terms of outcome. And even once again, whether complication was not significantly higher, it was higher. Okay, 15% when you use the hemodynamic support versus 7 or 8% if you did not use it. And once again, with a higher procedure time. So different study, but showing globally the same thing. So this shows that the outcome is not better. In terms of VT recurrence, it's non-significant, and even the patient without hemodynamic support did a little bit better. And mortality, and there are biased. Once again, when you look at all the cohort, and mortality was less in the patient without hemodynamic support. But even if you took the sickest patient with ejection fraction below 20% and NYHA class 3 or more, then there was no difference in terms of mortality. So what is the benefit of using hemodynamic support to map VT? And plus, there is this new study which has been presented at the late-breaking trials at last HRS in New Orleans by the team of the Cleveland Clinic, showing so this is a match control group with propensity score match with 80 patients and 40 in the Impella group and 41 in the Impella group, 41 in the without Impella matched. And once again, no difference in terms of efficacy and even in terms of death, LVAD implantation or transplant. So outcome is the same, even if you try hard to map the VT with hemodynamic support. But when you look at 30-day complication, this time it was largely significant, so more complication using hemodynamic support. And once again, you have an alternative. There is a substrate mapping. And Paolo told you that very well, especially now we have high-density mapping catheters. You do the map in sinus rhythm, and you try to work in sinus rhythm, and then when you induce, you position your high-density mapping catheter in the area you think is responsible, and within 1 minute, you can have at least a part of the substrate and know a lot of the VT, and then stop the VT and work in sinus rhythm. So why using hemodynamic support? And you can do the same. Pierre showed you these images. It was not intending to induce VT, but it mechanically induced VT just by catheter manipulation in the LV. And when you have several morphology, and we had 7 or 8 morphology in this case, even with hemodynamic support, it will change from one to the other to the other. So you start mapping one, but then it goes to the other. It's endless. So the idea there is to get an idea, of course, of inducing, having an idea of where is the substrate, which part of the substrate is more favorable for the VT. Start with there, but extending to substrate ablation, because otherwise it can really prolong the procedure and become a problem. And you mentioned the guidelines. It's a 2B recommendation for mechanical hemodynamic support in selected cases to allow mapping and ablation of unstable VT. It's a 2B, so it's not really in favor. But when you look at the studies that were used to do these guidelines, this is the one I showed you that showed no advantages in terms of VT recurrence, in terms of mortality, in terms of transplant. So I guess it's kind of part of expert opinion, and so it depends on which expert were in these guidelines favoring and doing hemodynamic support or not. And once again, based on very single center studies. So, and that's what you said, we don't have data to support the hemodynamic support for VT mapping and ablation. So to conclude before the rebuttal, hemodynamic support to low VT mapping and ablation is needed. Well, I don't think so. Is it feasible? Yes, it is feasible. But why using a strategy that has no benefit on VT recurrence, that has no benefit on mortality, LVAD implantation, heart transplant, that has more complication, it's proven, that costs a lot of money, and that has an alternative, substrate mapping and short mapping. So with that, I will wait for the rebuttal of Paolo. Thank you.
Briefly, have a rebuttal for a brief period of time.
No, it should be Mr. Frontera, isn't it?
Sorry, HS. Sorry.
In the meantime, I can just emphasize that we do mostly substrate-based ablation and analysis of more than 1,700 cases. We found pain SD score 0 predictive value because we had hemodynamic deterioration only in 1% of cases. And we do every type of patient, many of them in STORM. But we don't use general anesthesia on purpose unless we have intubated patient already. That makes a big difference, I believe. And you know, most of the cases, I agree with Fred, can be done without support. And really, this preemptive use could be very individualized, not based on some score system. This is my opinion. Of course, somebody like Paolo may have different, but this is what I feel is really important.
It is exactly the same thing. I have to admit that I wrote this chapter. I think the point is exactly where you left. There are situations that, according to your experience, can be managed, elective situations, where you have the pleasure of enjoying stable sinus rhythm and you can do all the games you want to. There are situations, the one that I showed you, that maybe you do not happen to receive, but I do receive an average of 2 times per month. And then, of course, you can't do without it. And I think that really, please, read also the other indication. There is a nice green flag, class 1, in selected patient at high risk of requiring hemodynamic support, and the risk stratification is not something that you put out from your head. It's something that should be set by protocol. The high-risk patient is everywhere the same in the world. And of course, you better don't do it. And you really should go on and take the decision to proceed to ablation, first of all, under hemodynamic support, in cooperation with specialists of advanced heart failure management, intensive care specialists, and also, 2A, in selected patient, hemodynamic support with ECMO actually should be used to avoid hemodynamic deterioration, because what you really want is to avoid the crash, to have the patient failing afterwards. So I think it is true, it's a cumbersome type of add-on. There is no study that will likely to be published on randomizing that unlucky chap that I showed you before. How could you do it without? So my recommendation is that, of course, everything that you can do during sinus rhythm, do it. Everything you can do with short-lasting mapping, do it. But anyhow, if you are in the process of setting up a VT ablation program, and if you are working into a high-volume center with cardiac surgery, with a program of VAD implant, you will receive such patients. And so you better be ready to treat them with hemodynamic support 1 day or 2 days that year.
Thank you very much.
I cannot agree more, and we'll agree on that. This is exactly my rebuttal for which patient and which system. And I think, as I showed you, except of ECMO, there's no place for other hemodynamic support than ECMO. I don't know if you agree on that, but at least all the different studies with impeller or things like that, it does not work or not very well. So if there is something to put, I think it's an ECMO. And the question is for which patient, and this is exactly what you showed, so I will not come back on that. And actually, I was a little bit, I was not very fair because you did a lot on hemodynamic support. It was all time. Now you are not using it anymore, as you showed us.
Not anymore.
Not anymore.
Less frequently.
But, and this is exactly what is written there, inability to maintain even short period of regular rhythm. You showed, this is the typical case you showed with incessant VTVF, and then you cannot stabilize the patient, so you will put ECMO to stabilize the patient, to bring in the lab, to try to avoid the bailout strategy during the case, because this is the worst case scenario when you have to put the hemodynamic support during the case. And if you have such a patient, it was during last Prague rhythm meeting with this kind of ejection fraction, then yes, you probably will need hemodynamic support for this kind of patient, which is very, very sick. He has almost no heart anymore. So in this case, of course, to prepare the ablation, but not, the idea is not to put hemodynamic support, to induce VT, to map into VT, and to stay too long into VT. So few tips and tricks. So in fragile patient, limit induction to the minimum. Don't try to induce, and to avoid shock and multiple shock if you can. Do not map VT for too long, because even if it looks tolerated in this sick patient, when they start to deteriorate, sometimes it's hard to bring them back if you stay too long into VT. Limit number of shock. Be careful to general anesthesia, it has been said, but general anesthesia is vasodepressive, so you have to be careful with your anesthesiologist in this sick patient with fragile hemodynamic condition. Stop on Tresto. So this is a question we can have. Our anesthesiologists ask to stop on Tresto before GA, and I start doing that even without GA, because sometimes I had huge blood pressure variation. Sometimes you never know whether it's normal or not normal, so some things. And use of multipolar catheter, yes, that's great, but be careful if it's not very dilated, it can be pro-arrhythmogenic too. So with that, I think we'll agree, and we can have with other type of support, but I will finish there for the sake of time. Thank you very much, and I think we'll agree at the end.
I believe there was a great debate and a very reasonable outcome of the debate, I would say. So everybody can get a lesson from this debate. So I pass now chairing to Fred.
So we will continue with another debate, interesting on identity mapping and whether is identity mapping necessary for successful VT ablation. So Antonio Frontera from Milan will go pro identity mapping catheter, and Frank Marchlinski don't need any identity mapping catheter to get successful.
Ladies and gentlemen, dear chairman, good evening. These are my disclosures. A little premise. When Joseph invited me to talk at TogetherVT, I must admit I was very enthusiastic. I read the title of the topic, is identity mapping necessary for VT ablation? So I exclaimed, wow, it's my topic, I like it. But then I discovered that my opponent was Francis, and I was a little bit nervous. So I remembered when I was a student in medicine in Rome, and I used to go to Vatican City, and my favorite place was the Sistine Chapel. Who does not know the ceiling of the Sistine Chapel? If you look at the top right corner of the ceiling, you will discover this picture, which is David versus Goliath. I'm not sure how it will end today, but I feel like David, and I want to reassure Goliath, Francis, no worries that we're not going to cut off your head today. And so what I did is to consult ChatGPT, and I asked, hey, ChatGPT, can you help to prepare the best ever slide made on identity mapping is necessary for successful VT ablation? And nervous because the opponent is Dr. Marchlinski. So not an easy task. Can you help? And as you see, Golia is also well known by ChatGPT. He wrote, when it comes to presenting against a opponent like Goliev, it's important to have a well-structured and persuasive argument. ChatGPT developed for me the entire presentation. Francis, I hope you don't mind. And I wish to thank ChatGPT. So according to ChatGPT, I should start the presentation from discuss the limitation of conventional mapping. Personally, I don't know the plan of Goliev. If in the intent to persuade you, it will start from one of his first paper about VT ablation, ahead of 3D mapping system. I rather believe that Goliev will try to persuade you that you need to just a quick substrate mapping with the ablation catheter. But let me say that there are so many limitations, Francis. I would be very afraid to perforate the LV, especially the lateral wall when you go transeptal. I see experienced operators doing that, or also retrograde. They perforate the LV, the apex of the LV in fresh myocardial infarction. Then it's not an easy task to reconstruct the LV or RV. You cannot achieve precise definition of the healthy and border zone and healthy and scar, and then you get long procedural time. How can we ignore the revolution of the last decade? In these last 15 years, multiple innovative mapping catheters have been developed. Think about the Orion, the HD Grid, the upcoming Optwell. Yesterday, I was flying, as most of you, to Prague, and during the waiting at the lounge, I saw this tweet of Roderick. What an assist, perfect assist for David to defeat Goliev. Also, Roderick was celebrating his first paper 13 years ago, on the first publication about multi-electrode multi-spline mapping catheters. And here you see the diastolic buffet mapped with the decapolar catheter. I think every of us has his own personal gallery of first procedure, the first EGM, the first AVNRT, the first VT. I will share with you my first HD mapping. It was one of the best periods of my life. I was just appointed as cardiac electrophysiologist by Paolo in Sacher Hospital, and it was the 2018. One experience. I remember that day I collected more than 25,000 points in this patient with RV dysplasia. You see the epicardial shell, and look how nicely you can distinguish the healthy from the low voltage area. But this advancement should not be confused only with the sole number of points. The big advantage is the opportunity to collect these tiny signals, which are what we like. And look how well you can define the near field from the far field. And I want to share with you this case done in Humanitas 2 weeks ago, ischemic cardiomyopathy with several ATP and BT on VT, 2 shocks. And high-density mapping in this case helped me to define very well in a few minutes where the match would be played. I can very well define the low voltage area and the electrical substrate, but why we do care about the electrical substrate? The information is very important, it's precious, because the electrical substrate correlates very well with the disease. This is one of our last paper published with Paolo. And how often we encounter cases where we don't know who comes first, the eggs or the chicken. Sometimes we have VT, non-ischemic cardiomyopathy, that then develop ischemia, or we have RV dysplasia, they don't have all the features at the CMR or the ECG. And when this is the picture from resume this paper, when we describe how lava limitation characterize the specific cardiomyopathies. I really like this picture. You see on the left panel, you have RV dysplasia. RV dysplasia starts from the epicardium and progresses through the endo, from epi to endo, and there is apoptosis of the cells, and so replacement by fat and fibrosis. So the scar is patchy. So there are many channels, and these many channels means that these are the late potential activity have low amplitude and have different timings on the HD grid. In this case, you see low amplitude and different channels, which express the different channels of the disease. Indeed, when you map ischemic cardiomyopathy, you have a different behavior, because here you have a solid block, a definite scar, in which there is one or two channels, and therefore you have a strand of surviving fiber in the middle of a scar. In that case, the HD grid will show you just one timing AGM and high amplitude. So here you have an example on how well you can, looking just at the high-density mapping of AGMs, you can differentiate non-ischemic from ischemic cardiomyopathy. The second reason why Goliev you must convert to ultra-high-density mapping is that with high-density mapping, you can define very well the propagation pattern. Here you see two lines of block, the entrance site are there, and here you have the lay potential activity. You see very well how many lay potential you can distinguish this site. And ChatGPT reminds me to explain how this enhanced visualization helps in identifying critical sites and abnormal conduction, abnormal electrical circuits. He is right, because where I see this lay potential, most likely I will record the full diastolic pathway. You see here the isthmus site, and a little bit later, just down here, the exit site. So Goliev, how could you do this with your sole ablation catheter? And why is it important to record the full diastolic pathway? This is the answer, is the manuscript we published. First author is Alexis Agis, myself and Paolo, demonstrate this very well. Have a look at this Kaplan-Meier curve. When you achieve the complete recording of the VT circuit, you have 12% recurrence rate. Indeed, when you record only partially or you go for subset mapping, the recurrence rate is up to 50%. This is indeed another research published 1 year ago, June 2022 on Nature. 61 patients were enrolled and whose ablation was guided by ultra-high-density mapping and had an improved 24 hours month outcome in comparison to patients with conventional mapping. VT ablation was associated with fewer VT recurrence on disease-related death during long-term follow-up in comparison to conventional mapping, and complication rates and other procedural parameters were similar in both groups. ChatGPT also wants to talk to me about the limitation of high-density mapping. I think there is only one, the inability to map in the 3 dimension. You can map just one layer at a time. But that's why in Humanita, since 3 months, we started our journey with ADAS 3D. So we are integrating our ultra-high-density mapping with imaging. This is a patient last week. We did a Chauke-Strauss, so a non-ischemic cardiomyopathy. We induced, she had 98 ATP and 5 ACD shocks. And we brought this to the lab, and VT was induced. Most of you would agree that it comes from the inferior apex wall septal. And here, this is the apex characterization. You see there is a mid-myocardium endocardial scar. And look how well there is a merge between the ADAS 3D and the ultra-high-density mapping performed with the HD grid. And the putative channel, not sure if you, yes, here. So the putative channel, according to ADAS 3D, was there. But surprisingly, when I looked at the lava lay potential activity, there were no lay potential at this time. But here, the VT was not possible to induce under GA. In that case, we tried harder, but we could not. But when, so I ablated at this site, and when I reviewed offline the EGM, indeed, there was a far-field EGM here. You see it's a lay potential for sure, but it's no spiky, high-frequency EGM. So I think this is mapping in the, something was in deep, and so has this shape very far-field. There were few EGMs like that. And here, at the end, non-inducibility of the procedure. So in conclusion, ultra-high-density mapping is necessary for the, I'm not saying it's necessary for VT ablation, but I'm rather saying that helps you to achieve the complete understanding of the electrical substrate. And if you reach this point, then the ablation is easier and is just a consequence. We must prefer ultra-high-density mapping, not only during sinus rhythm for better substrate characterization, but especially during VT. The electrical imaging of the VT ensures the best outcome. Goliev, Francis, will always remain Goliev, a pioneer in VT ablation, and we will continue to admire his work and his research, but many David in the world are growing up trusting ultra-high-density mapping. Thanks to all the research team in Marcus.
So you fight against two people, Frank. Again, Antonio Frontera and ChatGPT, yeah?
It's a tough task.
Yeah.
I need the pointer.
Yes.
That was a great job, and I'm a fan and an admirer. But don't believe him.
So you can go like this for the next slide.
Thank you.
Have the mouse for the pointer.
Okay. So I'm the con. That is high-density mapping necessary for successful VT ablation. The answer being no. And I'm not Goliath. Here's the list of disclosures. You heard him. He is an expert. He's a leader in the field on multipolar catheter mapping. He has more than a dozen publications. I read them all. They're all fantastic. And I acknowledge his expertise. I'm not an expert. Not on this subject, certainly. But I do 500 VT ablations every year. And I've been using multipolar catheters since I think you were in school, maybe high school, but certainly medical school. And so I have at least, as I say in the States, they say when you're involved with the field and have some level of experience, not expertise, but experience, you have a dog in the hunt. And so maybe it's worthwhile listening, at least listening to me. You may disagree, but maybe spend the next 10 minutes listening. I want to frame the argument because he sort of changed it at the end. He says, oh, it's good. We have multipolar catheters, and multipolar catheters allow us a better understanding of arrhythmias. I don't deny that. In fact, I believe in it. Okay? But that's not the debate question. The debate question is it necessary? Is it required to have multipolar catheters to be successful? I think the answer is obvious. It's no, not required. But let's talk more. So I want to acknowledge the fact that multipolar catheters have value, so you don't think I'm the true dinosaur. Okay, they have value. We've been using it for a number of years, and they have value. And I like these figures that we've shown, the sinus rhythm activation and this dramatic slowing of conduction, isochronal crowding, predicting the location of arrhythmia circuits. I think it's very important, and truly it's advanced the field. So many of the publications that you've had have truly advanced the field and advanced our understanding of the relationship between signals and arrhythmogenesis. And I love your AI stuff. You're going to be doing more, so you'll teach the world. All that's true. And listen, we have examples where we have situations where truly you can't record. This is an example of a non-ischemic patient who had inducible VT and then stopped having inducible VT. We made a decision to go to the epicardium to map when the endocardium had limited substrate. And when we got to the epicardium with a regular tip catheter, we couldn't identify any significant substrate on first blush. There was a little patch of scar right at the annular region. So We actually switched to a Pentaray, nice multipolar catheter, and began to see these little squiggles at the end. Said, let's pace. And when we paced, we actually brought out those signals. We ended up pacing that site, which was away from the dense scar, little patchy scar, mimicked exactly the ventricular tachycardia, ablated, and the patient never had another episode of ventricular tachycardia. So clearly, there are not only things we learn from having high-density mapping, but an opportunity in selected patients to improve outcome. But what is true, and what has to be acknowledged, is that VT ablation's been around for a while, and point-by-point mapping works, and ablation outcome using point-by-point mapping is very good. And I don't want to take the cream of the crop, my colleagues' authors' publications. I'm taking a multi-center outcome studies, 2 of them, pre-approval and post-approval thermal, 18 centers involved in these studies, taking a typical group of post-MI patients. And when you look at the outcome acutely, non-inducible, 75, 80%, 6-month outcome, dramatic difference in terms of the outcome, no VT on ICD during the 6-month follow-up in the majority of patients. And in the post-approval study, we had 3-year follow-up, and nearly half of those patients without any ventricular tachycardia. I think all those patients would disagree that they need to come back to the lab to get some high-density mapping. They had focused mapping that was successful. They don't believe what you're suggesting. They don't need to come back to the laboratory. Here's a clinical example. This is an add-on VT ablation. This frequently happens to us. This happened to me. Added on at the end of the day. Patient comes to the lab, gets into the lab at 3:30. I had a date with my wife. She was planning on having dinner out. She said, okay, you're going to be there. I said, no, I have an add-on VT. I'll see you at 9. Okay? Got to the lab at 3:30 and prepped. We're rushed. Clinical VT induction after doing baseline sinus rhythm mapping. The patient had hemodynamically tolerated VT. I was lucky, in a circumflex infarct. This was that arrhythmia. This is the sinus rhythm voltage map. I characterized a typical circumflex infarct, identified the 12-lead ECG, and said the exit for this circuit in this scar is probably coming from the apical aspect. We'll move our catheter into the scar, identified a mid-diastolic potential, stimulated, had a perfect endrainment response. It's now 4:32, and VT termination. We did aggressive stimulation, right and left ventricle. It's now 4:45, and I'm on my way to the gym and dinner. And I don't think there's anybody in this room that want to deny themselves this opportunity by doing a lot of detailed high-density mapping. And it wasn't necessary. Okay. Now, there's a history, and I respect history. David and Goliath, historical characters, maybe. Okay. Certainly, the idea of using different clues to identify how to ablate and where to ablate, a long history of using ECG, entrainment criteria, pace mapping to help characterize and determine where to ablate. And you can't deny that history. There's 20 years, and in 20 years of progress, incredible contributions by a number of people pointing the way to get rid of ventricular arrhythmias using a variety of techniques, from late potential ablation, pace mapping, entrainment mapping. All of these techniques work, and many of the techniques can be applied to unstable arrhythmias successfully. I like some of them. I'll show you just briefly. The pace mapping that Christian Deschilou pioneered, worked on techniques where he demonstrated can stimulate and pace, mimic the ventricular tachycardia that was occurring clinically, identifying when he gets deeper into the scar area, longer stim to QRS complex, transition to an area where the QRS complex changed completely, and identified an anticipated isthmus area that could be targeted successfully for ablation, very reliably and reproducibly from patient to patient. I also like one of the techniques that we pioneered, where I think we had an endpoint that you could hang your hat on, identifying a variety of potential indices of a ventricular arrhythmia circuit, whether that's characteristic lead potentials, good pace map sites, entrainment sites, but getting them corralled in a specific area and then encircling the area to make the inside the area inexcitable, with just like you would a pulmonary vein, where it have entrance block and evidence of exit block, and you achieve this endpoint. Look at this outcome. And I don't say this is necessary to achieve ablation. I say it's one of the many options that we have in a field that's growing. Okay? Finally, high-density mapping can be misleading, right? This was a clinical example where we're looking at the non-ischemic lateral scar, deep mapping with extra stimuli being performed, identifying with the deep mapping an area of decremental conduction over a small area in the lateral wall of the left ventricle. We said, aha, let's ablate. And I remember saying to the fellow, maybe we should induce first, and seeing a left bundle branch block VT morphology, and that's the only VT induced. And it was a classic example of bundle branch reentry, unrelated to what we found with the detailed high-density mapping. Pretty pictures, we can put them in a figure, some in manuscript someday, but having no value for this patient. So it can be misleading. Now, listen, I don't want to deny that there are advantages with high-density mapping, large sampling footprint, increased resolution. You get what you can do with multiple electrodes, of course, is rapidly perform entrainment mapping and pace mapping. So there really is value. But there are a lot more disadvantages. That's the reality. Or there are a lot of disadvantages. I won't say there's not necessarily comparable, but there are a lot of disadvantages that everyone needs to recognize in this crowd, right? There's the cost. There's the fact that you can't deliver energy, so you've got to either exchange the catheter or try 2-axis sites. Sometimes you've used 2-axis sites, you use the extra catheter. The high-density catheter is more thrombogenic, more at risk for developing embolic phenomena. You have to worry about another thing in doing a complicated VT ablation case. As already pointed out, in a small ventricle, you try putting in a multipolar catheter. Okay, what do you get? VPC, runs of ventricular arrhythmias triggered by the VPC, and you haven't had any information from your multipolar catheter yet. Very common. No contact force information, and there is a lot of artifact that's created, especially with these automated mapping systems. They'll improve over time, but right now, you get a lot of far-field signals, you get a lot of noise when you're doing multipolar catheters. There's a lot of overreading that has to get done, and editing that has to get done in order to interpret these signals, and you make the whole process a lot more complicated. And there's the anatomy. Now listen, I must admit, I want to confess, if I go to the epicardium, and we go to the epicardium a lot, I always use multipolar recordings. So I do. It's easy to move a catheter around the epicardium. This is just a decanav recording and showing that with an early non-propagated pacing stimulus that we have probably a good site for ablation. The fact is, when we added, in this case, an ablation catheter and turned on the power, we terminated the tachycardia. But before we terminated, we just looked at the signals and said, well, maybe we could have done it without the decanav. We've got the same signals in the middle of diastole, and if we spent a little bit of time recording, we would have identified the same signals with regular mapping. And certainly, the anatomy on the endocardium is pretty darn complex. Look on the left, the right ventricle. Okay, this is the tricuspid valve, chordae, trabeculations. You try putting in one of the multipolar catheters and map in detail. It works in a big infarct. It works if this is extremely dilated and you can get plenty of scar. But you try mapping anything that has smaller in size, and you have a lot of challenges. In the left ventricle, look at the papillary muscle and the chordae. A lot of things to navigate around in order to get a good map. a real challenge. So, this is the crowd. I want you to weigh the evidence. I presented the evidence, and now I want you to decide. I want everyone in this room to decide. And I think everyone will decide that high-density multi-electrode mapping is not necessary. The evidence is just overwhelming. Thank you.
You have rebuttal?
I did not prepare any rebuttal because I knew that he was smashing me, but what I can say is that
Yes.
I think, as I said in my conclusion, high-density mapping with the multi-electrode catheters help to understand the electroanatomical mapping, so to high definement, ablation then is a consequence. So I think that Francis can ablate with free multi-electrode mapping catheters with one ablation catheter, with one finger. He can do whatever he likes because he has his own experience, so he will definitely beat every mapping system. So in my opinion, if you have experience, you can really beat every mapping system. That's it.
Don't walk away. I do think he won the debate. I think, listen, mapping and the future of mapping is with multipolar high-density mapping tools. But it is a tool. Right now it's a tool. And we have to learn how to use it. And we have to learn its limitations. And we have to learn how to demand from industry how to make automated signal analysis a reality rather than a myth. We have to figure out which cases you shouldn't use it. So we still have some things to learn. But there is no doubt that it has helped us understand the physiology and helped us move this field forward. And this young man has been part of that. So congratulations.
Right conclusion.
Maybe if I can, Frank, if I can add something. I think we are at the beginning of new era also with ablation and mapping together. And catheters like Afera, Sphere 9, or new development also from Biosense and Boston Scientific, they all go in the same direction. So you will have a large footprint catheter with high-density mapping capability in one, all in one. You can ablate, you can map, you can use unipolar signal, close unipolar signals. So I think we are getting together, and in a couple of years from now, everybody will use these technologies and forget about solo mapping independent of ablation. So this is my belief based on some limited experience with these design catheters, and I feel that this will change completely our business in the next couple of years. So this is just to remark that we are at the beginning of new era. And then you guys will go together.
I think we're still together.
Yeah, I know.
My head's still on my neck.
Yeah, I'm joking.
Thank you very much. I think we'll have to end this session to go to the next one. Thank you. It was a nice debate. And we'll switch now for the EP case report, Young EP Arena. So I think I will let the
I will
floor.
invite Paolo and Katja. And we have actually quite nice cases. Some of them I was really surprised. I saw them, all of them. We have 5 today and 5 tomorrow. And we may select the best in our opinion. And if I'm not wrong, the first case should be presented by a physician who is from Ukraine, and he could not get a visa to get out from the country. So the case should be pre-recorded. Is that right? Okay. So let's start with this case, which is pre-recorded, and then other speakers should be here.
It's on Zoom, it's not pre-recorded.
Oh, it's on Zoom. Okay. Can we hear each other?
Yes, good day. Can you hear me?
Yes, yes, perfect. Okay, sorry, I saw that you pre-recorded the case, but now I see that we see much of Ukraine. This statue in the background, so you can talk.
Thank you. I really appreciate your support and support of Europe for Ukraine. Today I want to present you one of my first experience of ventricular tachycardia ablation. And I want to tell you that today all doctors from Ukraine faced a lot of difficulties, but with the worldwide help, we keep struggling. We are trying to help every our patient. So going to the clinical case, the patient is 65 years old man. He has a history for more than 10 years of different arrhythmias. As he said, in 2012, he had an aortic prosthesis due to the rheumatoid disease of the heart. In the last years, he had syncope and was diagnosed with tachybrady syndrome and persistent atrial fibrillation. Due to this, he received a two-chamber pacemaker, but there was no improvement. Looking through the statistical data on the pacemaker, there was found the episodes of sustained ventricular tachycardia, so patient was directed to our electrophysiological center for next evaluation. And on our first meeting, we observed this ECG with the ventricular tachycardia. Due to the worsening of symptoms, patient was already cardioverse. And on the next day, he was already in EP lab, and VT has continuously started again. So firstly, we had the EP study and electroanatomical mapping in the right ventricle with the help of decapolar rowing catheter. Here you can see the angiogram of the ventricular tachycardia from the right ventricle, but we haven't found any signs of interest. And due to the ECG localization, it showed that mostly the left ventricle. We went to the left via transseptal puncture, but it wasn't so easy. Dilated chambers and the fluoroanatomical orienters were not clear. So after the puncture, the contrast was not clearly showed that the needle was in the left atrium. But after the injection of contrast through the introducer, it showed us the severely dilated left atrium. So we felt more sorry, something. Oh.
So you got stuck?
Yeah, something wrong with the PowerPoint. Maybe I'm sorry.
Try escape.
Yeah.
And share again.
1 second.
Try to share screen again. Or you can go directly, skip that slide.
Yes, do you see the PowerPoint?
Okay.
Yeah. So after that, we made electroanatomical mapping of the ventricular tachycardia in the left ventricle, and we found the origin site of ventricular tachycardia from the lateral basal wall. And we performed the entrainment on this side, and the best PPI interval was about 470 milliseconds from the left ventricle that we had with the tachycardia cycle length of 440. In this zone, catheter was stable, the applications were adequate, but the ventricular tachycardia were stopping and started again spontaneously, started again after a program installation. So we repeated some series of applications, but no effect. So we tried to map again, and we tried to involve the left atrial appendage. And on the propagation map, we found that there was the slowest conduction in the left atrial appendage. So we tried the radiofrequency application there, and after the first application, we succeeded, and ventricular tachycardia stopped. But the applications were not really ideal, so we needed to make 8 more applications from left atrial appendage. It was very nervous. The watts were not really ideal, and the impedance were just rising. But after the last applications and control time for 30 minutes, there were not sustained ventricular tachycardia induced. The total time of procedure was more than 8 hours. So to conclude, I want to tell that radiofrequency ablation from LA is mostly avoided because of putative risk of perforations, but it can be used when other approaches have failed. And moreover, different forms of left atrial appendage can help us with different locations, such as in this case, we had success with the basal lateral wall of left ventricle, and a lot of information there, like with the LV summit. So I want to thank all of you for your support and attention. If you will have questions, I will be happy to discuss.
Thank you, Mikhailo. Is there any question from the audience or from panel? Are we still connected? Are we still connected?
Yes. Yes.
Okay. So,
May I ask you one question? First of all, congratulations, a very nice case presentation. Did you have some concerns regarding the coronary arteries? Did you do any imaging, or did you shoot the coronary arteries just by an angiogram to see that you are safe?
Yes, of course. If we are going through the left atrial appendage, it is necessary to make sure that it is safe, that coronary arteries are apart, and we cannot damage a lot coronary arteries. But unfortunately, we had cleared the server, and I couldn't just take them to the presentation.
okay. Any more question or
I
comment?
have a question for you. Congratulations, Michael. My name is Paolo Della. What were the power settings that you needed in order to go through the atrial tissue in order to achieve ablation to the ventricle?
We had the 40 watts and we used the flexibility catheter just to irrigate because there was, without irrigation, we wouldn't have great watts to perform. The 40 watts.
Thank you.
Okay. Well, there is no other question. Thank you, Mikhail, very much for your presentation, and I hope next time you will be able to travel again and join us in the next edition of the meeting. And good luck to you and all your country.
Thank you. Thank you for your support.
So the next presentation should be given by Dr. Moshe Acha. I'm sorry, I don't know exactly from which city you are, but because I don't have this information here. But
how do I operate this just for all?
yeah, I know, but from which town, I don't know. From Jerusalem.
I'm from Jerusalem, from Shaare Zedek Hospital, and I want to present quite a unique case that we had of the post-receptal process VPC ablation. So this was quite a routine case of a 57-year-old man who was admitted with heart failure symptoms and multiple VPCs on the monitor, with no obstructive coronary disease and cath, and severely reduced LV function, with an MR, CMR that confirmed this severe LV dysfunction, but really non-significant late gadolinium enhancement. And then the DD was between tachymyopathy or some dilated cardiomyopathy, to know that the endomyocardial biopsy didn't show myocarditis. So the patient was started treatment for heart failure symptoms, and you see here that he had two dominant VPCs, basically. One with this, both with a left bundle pattern, but one with this inferior discordance with a reverse V2 pattern break, meaning that the R in V2 is greater than the V1 or V3. And he had a type 2 VPC, again, late bundle pattern, very early transition, but this time left superior axis, and both are quite narrow. So the patient continued to have heart failure symptoms, and with this significant VPC burden and suspected tachymyopathy, we decided to go for ablation, hoping that we would obviate the need for an ICD if he will improve and get better. So to get ready for this ablation, I read the Marchlinski paper, speaking about inferior discordance, and speaking when you have a positive 2 and a negative QRS in Li3, you should think about moderator band or parahesian. And basically other papers showing that when you're looking for very early transition with a late bundle pattern in an inferior discordance, it should point you to parahesian region. All right. So we went for this mapping. This was the dominant VPC during the ablation, was like that type 1 with the inferior discordance. And the mapping, I'll show you better images later, but the mapping really concentrated on the parahesian region, and we got a quite early 40 millisecond pre-QRS signals there. But despite multiple applications and trying with the Agilis with quite a good contact, and even then we did not succeed, and we went through internal jugular also because of the issue of that maybe the tricuspid annulus may interfere with the touch, with the contact, but this was not successful. It took time, and the patient got restlessness, and we stopped. And we understood that we need to do something, and we need to think more. So the patient was discharged with a life vest, with a therapy, and got better, and really with a fleckenite, tambour, and he came later with really almost no VPCs, and his ejection fraction got better, and clinically got better. But the patient didn't want to continue medication. So now we knew that it is tachymiopathy, and we knew that we needed to go for a redo ablation, and this time to succeed. So we now looked further in the literature what's going on with our anatomy. So the first paper we found was really dealing with this left postural superior process, and speaking about this unique anatomical position where the ECG characteristics serve a right bundle or a left bundle with an early transition, with monomorphic R in lead 1 and the R amplitude in lead 2 greater than in lead 3, which are basically found in our case. So this was our type 1 VPC, which basically answered all of these characteristics and looked quite the same as one of the cases that were presented in this paper. Okay, so we got to know that we are probably dealing with this area. And then looking with other publications as well, speaking about the basal infraseptal area, which are basically close by, and you know, these places are probably, each people call them differently. Again, speaking about right bundle or left bundle with early transition in all left superior axis, reverse V2 pattern break, and quite narrow VPC complexes with. Notable that they reported that 90% require mapping of 2 or more chambers, and 40% required ablation from multiple places. Now, I think that is what I want to go back just a bit to speak about the anatomy, so you can see that this process basically is really in touch, both with the RA, with the RV, and with the CS. So we acknowledge that we are going now with an ICE and looking for multiple chambers to look into this location. Notably, the type 2 VPC that the patient had was similar to these few of these VPCs that were presented in the basal infraseptal region paper. All right, so now we went for this ablation, this time with ICE, and we started looking with multiple chambers what's going on. So we started with the CS, and we found, I don't know if it will run, but we found like a mid-cardiac vein going very proximal. We went after the manipulations with the ablation into it and found pretty early signals there. All right, so then we went into the RA, into the endocardial LV, and we found basically quite early but similar activation in both the LV endocardium with 35 milliseconds per QRS and the LV endocard with, again, the same activation earliness, being similar activation pattern, being both 35 milliseconds before the QRS. We started ablating from the LV posterior superior process, and we saw that the VPCs ameliorated but continued. We went then to the RA, and it was basically between the lower tricuspid annulus and the CSOs. And again, we saw that there are less VPCs, but still continued. Interestingly, what happened is that only after we have succeeded to see in ICE that we have homogeneous scar created between the post-receptal process and the opposite anatomical location in the RA, did the VPC stopped altogether. So we learned that the fact that both the RA site and LV posterior superior site showed similar activation times, the fact that the patient had 2 VPC morphology representing a periodically close by region was suggesting probably of an intramural origin between the RA and the post-receptal process. And we also learned about the usefulness and the critical idea of using the ICE to show you that to have a really homogeneous scar, because we were really ablating from the same places, and only when the ICE showed us that the confluent scar was going from the RA to the posterior superior process, that the VPC were finished. The patient was discharged and he felt better, his ejection fraction improved, no heart failure symptoms, and is quite okay. So the conclusion from this case is that some VPC ablation necessitate a full thickness scar around the VPC origin to succeed. Ice is of utmost importance, guiding both anatomical opposite site approach, verifying ablation contact, and enabling visualization of free-time visual ablation-induced scarring. And the fact in this patient, the fact that we have few VPCs morphologies, identical activation time from both the LV endocard and the RA sites suggests, as we think, intramural origin. Thank you.
Thank you very much. Paper is open for discussion. You can stay here.
Hello. Is it on? Hello, good afternoon. I'm a EP fellow, so I'm beginning a little bit in this path. But I wanted to ask you, did you consider the possibility of doing bipolar ablation at that region, that you have something very intramural?
Can you repeat the question?
Bipolar ablation, if you consider bipolar ablation between.
Well, you know, I think this would be the next step if we would not succeed from going first with the LV and the RA. Probably so. Yes.
Thank you.
I would certainly try in this case to go with the help of intracardiac echo to go beneath the septal leaflet of the tricuspid valve, where you get really, you are covered by the fibroskeleton, you are very close to his and to membranous septum, and you can do ablation. Sometimes we see that it goes more to the right, sometimes to the left, and sometimes can be done with precise mappings. You get a little better prematurity compared to going from left side or from right atrium. So, but I mean, it's difficult to say, but I have this experience with similar ECG pattern, at least as number one ECG, what you showed. Frank?
Very nicely done. I always have a question, though, when people talk about intramural. And you start out by saying it's because you ablated from both sides and it stopped. And then you said because the activation times were equal. So I buy the activation times being equal, and that's strongly suggestive. Always when you're giving that second lesion, right, and it's the opposite side, you always wonder, was it the second lesion that actually eliminated the VPD? And it's when we review manuscripts we question, so I question you now.
I tell you, I think, so first of all, when we mapped the identical times before ablating, you think of it, what would cause identical things to go from, you know, both opposite directions? And the fact that you have two morphologies that are basically both eliminated. So you can argue, okay, that my morphology went from one side, the other for not, but they continued until it was all done from both. Meaning that nothing happened with one ablation, nothing happened with the second site until we did it and we covered the whole area. And and it was a really strong feeling here with the ice, because we did multiple ablations from the LV endocard, it didn't finish. Multiple ablations from the RA sites, it didn't finish. But then when we looked at the ice and we saw that there is hyperechoic region and there was something in the middle left and we needed to go further, stronger from both sides, only then it succeeded. So
that's a good defense. Now, how did you, what did you do to achieve that again? What did you do in terms of power? Just a longer lesion?
Yeah,
or?
I think, so, you know, I don't recall exactly, but we did increase the power and we did go for further ablations. Basically, the ice showed us the more ablations we could do, we could have a deeper hyperechoic there going with the ice. So really, it was the ice-guided ablation there, and this was the first case for me to see that without the ice, I would do, you know, stop before and say, hey, it's not successful, I don't know what to do. It was that region, and the fact that we got prepared, knowing that this is the region, and we should be successful, and to really not give up before we see the confluence of the hyperechoic regions going from one side to the other. Yeah.
More questions?
Actually, also my comment is the power setting, but also the length of the lesion, because nowadays we more and more tend to do very long application to reach deeper substrates, and then probably start with the most safest position first, and then go to the more risky positions in terms of damage of adjacent structures. So, how is the length in your lab? Is it 60 seconds or?
Well, here we went more. We went like 90 seconds and more. Of course, following the impedance drop, now to see that there is some rise or something. But really, I'm saying it was only the ice that let us know that we still had more work to do in this place. Yeah.
Good to hear.
Thank you very much. You must be happy.
Okay, thank you very much again. And we have a third speaker, Francesco de Senza. He will show us his case.
Good evening. My mic.
Yeah, it holds.
Okay.
So just order.
Okay. Okay, mic is open. Can you hear me? Yes. First of all, good evening, you all. I want to thank, first of all, the organizing committee for choosing my case for presentation. It's a privilege for me to be here today with you all. So this is another PVC case. This is about a 45 years old gentleman who was referred to our AP unit for PVC symptomatic for palpitation and fatigue. All the imaging exams he underwent, first and second level, were unremarkable. And this is the basal EKG at the ambulatory visits. I give you a few seconds just to see it. You notice lead 1 is positive. Inferior leads are predominantly negative. There is a left axis deviation, a left bundle branch block morphology with no transition on precordial leads. These are interpolated PVCs, very late. We made an alter on this patient, and here PVCs are earlier, and the QRS is such wider with some notch in inferior leads, in lead 1, but also in V5 and in V6. He had an elevated burden. We tried to treat him with beta blockers, but the beta blocker therapy was ineffective, so we scheduled him for ablation. So when approaching this kind of morphology of PVC, we have to deal with the difficulty with the knowledge of the anatomy. And I want to continue where Professor Marchlinski has left us with his brilliant presentation before, about the complexity of the intracavitary anatomy. In fact, if we cut the anterior wall of the right ventricle, there is the chamber of interest for this kind of PVCs. We have to deal with a lot of intracavitary structures, and most of them host the right bundle branch. And in my opinion, right ventricle anatomy is even more complex than the left one. Just because the tricuspid valve has 3 leaflets, not 2. We know the anterior superior, the septal one, and the inferior one. And so it does mean that we need at least 3 main papillary structures to sustain these leaflets. And here they are. We have the medial papillary muscle. There is a very little muscle attached to the septum, but it provides chordae for the superior leaflets. We have the most prominent one in the middle of the cavity, the anterior one, and then just another little muscle, the inferior one. But look how much variability is from patient to patient in the representation of these muscles. The septal leaflet is anchored to the septum with a lot of tendinous chordae at very, very little papillary muscle attached to the septum. And after, we have also other important septal structures, like septomarginal trabeculation. There is the direct continuation in these patients of the medial papillary muscle. And the septomarginal trabeculation continues onto the moderator band, moving from the septum to the anterior wall. And in fact, the moderator band terminates into the apical trabeculation, but also at the base of anterior papillary muscle. And this is why when we navigate the right ventricle, we have to consider that we can have PVCs from all these sides, and we can put the tip of our bladder on the moderator band, but we have to see it before, or onto the anterior papillary muscle. And we have to consider also to fall in the trabeculation. The trabeculation starts in the middle of the cavity, but goes further into the apex. And look in these beautiful images, how the tip of the ablator in the real apex is far from the middle of the cavity when originates the anterior papillary muscle. So this is why when we approach this kind of PVC ablation, we use always intracardiac echocardiography. Before we start to trace the external boundary of right ventricle, the anterior wall, the diaphragmatic wall from the home view, and we reconstruct it in a 3D map, in a three-dimensional map. And but just moving and rotating the probe in the home view from the right atrium, we are able to visualize sometimes the inferior papillary muscle. There is attached here to the diaphragmatic wall, and we start to reconstruct the intracavitary anatomy of the right ventricle. And then advancing the probe into the RVOT at the base of the outflow tract, we can start to rotate clockwise, and we can start to reconstruct all the septal structures, starting from the septomarginal trabeculation. And moving with a clockwise further rotation, we can visualize the moderator band. Here you see the septum, LV, septum, and the septal attachment of the moderator band. But also you can reconstruct all the entire 3D volume of the band. And this is just a video to see how you can move and rotate the probe just to trace all the boundaries of these muscle structures. But further, we anti-clockwise the probe, and we started to see the anterior attachment of the moderator band when the moderator band terminates into the base of anterior papillary muscle onto the anterior wall. And with a look at the anatomy, you see a perfect correspondence. With a further anti-clockwise rotation, we have only the anterior papillary muscle, and then the apical trabeculation, moving the probe toward the apex with an anteroflexing, we see all the trabeculation, and we trace it, and look again and front with the anatomy. How far is the real apex from the starting of trabeculation and the starting of the base of these important muscle structures? So, this is the complete final reconstruction of our ventricle, of the ventricle of our patients. And looking at the anatomy from the spacement, you can compare it easily. In these patients, we started navigating and mapping our PVCs. And I'm showing you this image doesn't contain a complete high-density map of the whole right ventricle. I made only few points, I tagged only few points onto the moderator band, point by point with the ablator, just to see that the propagation went from the anterior wall to the septum. Here the red color, here the late colors. And here there is the earlier potential we able to record it. The pace map in this region we know is not always perfect, but we obtain a 90%. And finally, let's go to the ablation. Here you see, I want just to see the first phase of the ablation where I target these points that are my target points, but I didn't reach them. In fact, I was into the trabeculae. And so I tried to visualize from another view, just rotating the carto. And you see here, unsuccessful ablation was under the right spots. Here, yellow tags tagged the right bundle potential. So, in the final of this video, I reached, with carto replay showing me how was the catheter during mapping, I could able to reach the right spots and made my effective ablation. So this is my case. We performed an ablation here. I don't know how do you want to define this, if moderator band is base of the anterior papillary muscle, if trabeculae, but I kept I kept them. And this is just to show that knowledge of anatomy is crucial for a successful ablation, and in my opinion, for me, also use of eyes. Thank you very much.
Thank you very much. Again, paper open for discussion or comments.
If I may, a question. Congratulations, very nice. When you do this, do you help yourself with a stabilizing catheter, with an introducer, a steerable introducer, or do you do it bare catheter?
No, I used Agile sheets. Agile sheet because without there was no stability. Stability is the real matter during this kind of ablation. I just forgotten to show you the stability at the final ablation is perfect. It was perfect with 25 grams, but with Agilis, of course, with Agilis.
Any more comments? Frank?
I think this is a nice example of, again, that anterior papillary muscle. And maybe lead one was a clue on the VPD, that it was more posterior towards the valve because it was so positive in one. Many of them are marginally positive as it inserts a little bit more apically.
Perfect observation. And do you think that the notch in lead one, in V5, V6 could sign the region from the base of the anterior papillary muscle because of not so proximity to the right bundle branch?
Right. And not close even to the septum as a consequence. So the sequential activation of the two.
Yes. Thank you for the suggestion.
I have a very short comment. I noticed that you showed the activation on the papillary muscle, but only with the M1 and M2. And on the presentation, there was not M3, M4. So I'm just wondering, at least in this image, and later on it was both displays. I'm just wondering, do you use this, because you have certainly one catheter with 4 electrodes. So are you using for this cases the sequence of M1, M2, M3, M4?
Okay, just I want to retake this. What are you meaning? Yes, map 1-2. Map 1-2 because just only because of to make spaces. I used the other mapping, the proximal catheter, but not showing here in the trace. Just to make larger the trace for you to a better visibility.
I just want to make this comment. It's very helpful. We actually use M1, M2, M2, M3, M3, M4. So you have a kind of high density mapping on your ablation catheter, which gives a little bit the guide for the direction how to move the catheter. I personally find this very helpful. But certainly you use it during mapping, but you did not display it. So
Thank you very much.
It's useful when you use rowing, not a point mapping catheter, because then obviously you see it all the time. But when you use a single catheter, so it's very useful to get orientation immediately and goes up and down, proximal, distal. Okay, good. Thank you very much. And we have last two. Marta Skowrońska from Poland, I believe. And she has an interesting case on the missing puzzle. Of course.
Hello, thank you. I will be presenting in lieu of my... Hello, thank you. I will be presenting in lieu of my boss, Jakub Baran, who unfortunately could not make it. I'm very grateful for this opportunity to be here and present our case on our patient with non-ischemic cardiomyopathy, VT, and the use of endomyocardial biopsy. This is a 62-year-old gentleman who was referred to our institution for VT storm ablation with non-ischemic cardiomyopathy, first diagnosed in 2008 after an at-home aborted SCD, Of unknown etiology, no cardiac magnetic resonance or endomyocardial biopsy was performed at time of diagnosis. A coronary angiography was obtained with no coronary lesions. He was discharged back in 2008 on optimal medical treatment for heart failure and had an ICD implanted. Around came 2018, this patient suffered ICD battery depletion, was simultaneously upgraded to CRTD. In 2020, this patient experienced cardiac device-related infective endocarditis, had the CRTD explanted, and another one implanted via the right subclavian vein on the right-hand side. Since 2021, this patient experienced at least 3 episodes of fast VT in the VF zone of detection, the latest in April 2023. This was followed by 6 unsuccessful shocks from the device, followed by external defibrillation with return of sinus rhythm. The patient was started on amiodarone and referred to us for VT ablation. Other comorbidities included permanent atrial fibrillation, COVID, ischemic stroke, and epilepsy secondary to ischemic stroke. On admission to our institution, this patient was normotensive on biventricular pacing with no signs of decompensated heart failure, with markedly elevated NT-proBNP levels up to 4,000. Transthoracic echo revealed a very low ejection fraction of about 20, a dilated left ventricle with virtually no normokinetic segments apart from 3 basal segments. And this was, and also moderate aortic regurgitation and tricuspid regurgitation was revealed. Here shown are the IEGMs with these 6 unsuccessful shocks for an arrhythmia with a varying cycle length of about 200 milliseconds, followed by the successful external defibrillation. Around came April, we attempted VT ablation. Professor Baran routinely uses intracardiac echo during many procedures, including VT ablation. And here presented on the left-hand side is the eyes view from the right ventricle towards the left ventricle. And we discovered no apparent scarring except for some intramural whitening in the lateral wall and some visible thinning. We performed bipolar voltage mapping, not maybe so unsurprisingly, discovered no low amplitude areas in the left ventricle looking at the intramural location of the whitening, and local activation time showing a border zone of late activation depicted in blue on the right-hand side of the left graph. We attempted inducing sustained VT, but this was unsuccessful on both lack of and on isoprenaline infusion, and we obtained only short NSVT runs. Our next step was pace mapping. On the left-hand side, you can see the obtained short NSVT run, and on the right-hand side, pace mapping, and we may appreciate some similarity between the 2 obtained morphologies, with some differences in lead 2 and 3 with apparent notching during pace mapping, and some differences in V6 that we attributed to the intramural location of the substrate. We moved on to RF applications. Using an Agilis steerable sheath, a thermocool smart touch catheter was introduced, and Professor Baran attempted a slow cooking approach with a lower energy of 25 watts with applications prolonged to an ablation index of 550. There was some unsatisfaction and some air of suspicion regarding this ablation. The patient was non-inducible during the procedure at the beginning, so we had no endpoint of non-inducibility in the end, and we decided to move on to endomyocardial biopsy. This patient also had a history of undiagnosed non-ischemic cardiomyopathy, had unsuccessful shocks delivered from the device, so we attempted to look into the etiology and perhaps into further medication for this patient. Professor Baran introduced the biopsy forceps through the Agilis steerable sheath through a transseptal approach and obtained 5 samples, 5 specimens, 3 from the left ventricle from the region of whitening between the left anterior papillary muscle and the inferior region below the lateral side of the mitral valve annulus, and the additional 2 samples from the right ventricle. Here on nice imaging, we may sometimes see these biopsy forceps taking the samples. We were somewhat surprised by the endomyocardial biopsy result, which showed chronic on active myocarditis. This was evaluated using the Zabja classification. This is a classification that was first published in 2001 in Circulation, and it is largely based on the upregulation of HLA expression on cardiomyocytes. This was present in this patient's specimens, as well as infiltration with macrophages and T cells. All this together made the patient eligible for immunosuppression. We ran some additional blood work. We found no antibodies in the blood. We found no evidence for active viral infection, either by serology nor by PCR. And after some external consultations, we decided that cyclosporin and steroids were the most promising immunosuppression regimen for this patient. On the left-hand side is the immunohistological staining of the specimens with collagen fibers shown in blue, so an infiltration of collagen fibers between healthy cardiomyocytes. The further management of this patient was PETs with glucose, which we performed to see whether there was any increased metabolic activity as a surrogate marker for inflammation, but the results of this study were unremarkable. The final diagnosis for this patient was chronic active myocarditis with macrophage and T cell infiltration. Due to a history of unsuccessful shocks, this patient was referred for subcutaneous ICD implantation, which was successful. We plan to follow up this patient at our institution after 1 month and 3 months of immunosuppressive treatment. Up till now, this treatment has been well tolerated by the patient. Our goal right now is 6 months of immunosuppression followed by TET assessment. We hope to see no further decrease of the ejection fraction of the left ventricle. And this patient remains on amiodarone until further assessment. So our conclusion is that in this specific case, endomyocardial biopsy was very helpful in managing further treatment. Thank you.
Thank you very much for presentation. Any comments or questions?
I have a question. There is some discrepancy between the biopsy findings that are obvious and the presenting arrhythmia pattern that stays for a monomorphic VT, whereas, at least in our experience that has been reported, in the chronic phase, you most likely have inducible polymorphic or spontaneous polymorphic, non-sustained, rather difficult to have a monomorphic and so resistant to treatment as your tracing proven. So what is your idea that this is a long-lasting process with reacutization?
I believe there may be 2 possible reasons. One is 2 diseases in one. So a person with a other etiology of non-ischemic cardiomyopathy, which we did not diagnose up till now, and an addition of active myocarditis, which I believe may be possible because these patients' medical history goes back 14 years, spanning 14 years.
And the second question for me would be, why didn't you go on epicardial mapping? Because you might have found something a little bit better. And just to finish, when you do that, why do you keep BIV on? If you are looking for conduction delay on the left wall, shouldn't you just turn it off? But just as a curiosity.
Sure. So this patient had no underlying hemodynamic rhythm for us to turn off the pacing during the ablation procedure, I believe. And my second answer is that, sure, epicardial access would be best, but we do not perform this at our institution. So Professor Baran performs it, but not in this institution.
I have more or less the same questions. Okay, so thank you very much indeed. And so we are moving to the last presentation, which is by David Rizzello. And
thank you. Okay.
The case is again about myocarditis. Yeah. Okay, great.
Yes, I want to thank the Scientific Commission for giving me the possibility to be here. I'm a cardiology resident from the University of Parma, and no, okay. Okay, so I will present a case of an unusual ventricular tachycardia in a patient with dilated cardiomyopathy developed after an acute myocarditis. And once again, we want to underline the importance of making a correct diagnosis before going to the EP lab. So, our patient was a 52-year-old gentleman with multiple cardiovascular risk factors that in 2003 was diagnosed an hypokinetic dilated cardiomyopathy developed after an acute myocarditis. In 2017, a transvenous single-chamber ICD was with a single coil lead was implanted in primary prevention due to a severely depressed left ventricular function. In 2021, the ICD delivered an appropriate shock for a ventricular tachycardia with a mean second length of 345 milliseconds. And additionally, an ambulatory altered ECG monitoring was performed, demonstrating frequent monomorphic PVCs and a negative QRS complex in the inferior leads. The patient was already on beta blockers, while amiodarone was contraindicated due to a pulmonary fibrosis. So the patient was referred for an electrophysiological study and catheter ablation of the ventricular tachycardia. But at the time of the admission, only the stored ICD EGMs recording during VT episodes were available, representing the only clinical documentation of the arrhythmia. So, a non-invasive programmed stimulation via ICD leads was performed to induce the arrhythmia. And VT was induced by 3 extra stimuli with coupling intervals of 260, 240, and 240 milliseconds, and a basic drive cycle length of 600 milliseconds. The very interesting thing was that the analyzing the ICD EGMs of the VT recording during NIPS, it was equal to the one stored by the ICD. So, in particular, the relative short interval between the VT QRS onset on the far-field ventricular EGM to the local activation time recorded on the near-field ventricular EGM supported an hypothesis of an endocardial site of origin of the VT. These findings were also consistent with a possible septal exit site of the arrhythmia. At the ECG recorded during the NIPS, VT QRS complexes displayed an LBBB morphology, an early precordial transition by lead V2, a leftward superior axis, an R major, then S in lead V6, a monophasic R wave in lead 1, and absence of deep Q wave in AVR lead, suggesting an origin from the posterior septal process of the left ventricle. And according to ECG criteria to differentiate endocardial and epicardial origin of arrhythmias originating from this region, at least 2 out of 3 of these were consistent with an endocardial origin of the tachycardia, such as the initial R wave in the inferior leads and a maximum deflection value index minor than 0.55. So, put together, all these findings were suggestive of a VT originating from the posterior septal process of the left ventricular endocardium. Electroanatomic voltage mapping ruled out the presence of a myocardial ventricular scar. Mapping ablation catheter was placed into the left ventricle via transeptal approach, while a 4-French decaporal catheter was advanced in the middle cardiac vein. Local ventricular activation preceded surface QRS onset by 50 milliseconds at the site of the PSPLV area during VT, while mapping of the PSPLV from the adjacent infromedial right atrium showed a broad ventricular signal earlier than the QRS onset and the middle cardiac vein, but slightly later than the signal recorded from the ablation catheter. So, application of radio frequencies at the earliest ventricular activation site resulted in complete suppression of the clinical VT within 2 seconds. And after the lesion was consolidated, no further induction of any kind of the arrhythmias, the clinical arrhythmias and other types at programmed ventricular stimulation occurred anymore. So, Ventricular arrhythmias from the PSP area are rare and can pose unique challenges during catheter ablation due to the anatomic complexity of this region. We reported an uncommon case of VT arising from the PSP area in a patient with dilated cardiomyopathy developed after myocarditis, but without evidence of myocardial scar in the site of origin of the arrhythmia at electroanatomic mapping. In the absence of pre-procedural imaging data, the 12-lead ECG of VT may provide clues to predict the origin of VT. Thus, ECG features still have a central role to predict the site of origin of ventricular arrhythmias. However, even the 12-lead ECG of spontaneous VT is often not captured prior the ablation procedure, and stored ICG ventricular EGMs of VT events may represent the only clinical documentation of VT. This may simplify the localization of ventricular arrhythmias. And the relative timing of far-field and near-field ventricular ICD EGMs from stored clinical VT events can be helpful to predict the site of origin of arrhythmias. In conclusion, a proper pre-procedural identification of the putative origin of the clinical VT is of importance for differentiate procedural aspects, including the access for mapping ablation catheters. Right atrial approach represents the first way to attempt mapping and ablation of the ventricular arrhythmias from the PSP-LV, suggestive of an endocardial origin of the arrhythmia. And given the close proximity between right atrium and ventricular tissue in this region, ventricular arrhythmias from the PSP-LV endocardium can be targeted from the right atrium, and together with the catheter advanced to the middle cardiac vein, this helps to choose the better strategy to ablate arrhythmias originating from this region. Thank you for your attention.
Thank you for your presentation. Again, questions, comments?
Thank you, very nice presentation. I would like to change a little bit because you state quite repeatedly that you exclude SCAR. So how did you exclude SCAR?
Well, so we perform, at first we have to say that we managed to do a CMR that the patient was not, the patient had a scarce adherence for the test. So this was, this led the case to be more challenging. Then making a unipolar voltage mapping and bipolar voltage mapping, any kind of scar was detected in during mapping of the left ventricle. So we excluded the presence of an endocardial or an epicardial, of an endocardial scar, as our approach was endocardial.
Any other question? Frank?
At a certain level, you have to worry about compact AV node, right? And at what level do you give advice that maybe ablating from the atrium is riskier than ablating from the ventricle?
No, I didn't understand completely the question. So,
okay. At a certain level, when you're ablating in the atrium, there becomes a greater risk
the compact node,
of ablating the compact AV node, right? So were there ECG features where you think that that does not apply and this is low enough that if you ablate from the atrium, it'll be safe?
Okay, but the question is that we were scared that we could not ablate completely the tachycardia if we approach the arrhythmias from another region than the left ventricle, as we managed to reach the PSP from via transeptal approach, and so.
No, I think that sometimes, I guess I'm just implying that I thought your sentence said the right atrium may be a good consideration.
Yeah,
but actually,
because
this one I
we saw
prefer to ablate it in the left ventricle. This example, I would have preferred to ablate
okay, okay.
it in the
At
left
least,
ventricle.
okay, to try from the left ventricle. Okay, yeah. Okay, thank you.
Okay, so if there are no more questions, I feel that we finish long day. I hope that you enjoyed discussions and especially nice lectures and also live cases. And this brings us to reception, which is outside in this foyer, and then faculty members will collect together afterwards, and we go for a dinner and for discussion afterwards. So feel free to enjoy this reception, and then tomorrow morning we start again at 8:30, and there is again packed program with also 5 cases of this investigator session. Okay, so have a nice evening.